Yes, sir. You can start, sir. Yes, sir. You start, sir.
Okay. Good evening, all my teachers and my dear students. Today's topic is stiff elbow. This is commonly given as a short case in the examinations, but this is a complicated one. We have to know everything about this. Why? Because a good history taking is very important in this case to obtain a diagnosis, and you should know the biomechanics of the elbow. Then only you can understand what is the flexion contracture, what is the extension contracture, and what are the implications that are responsible for this, and how to correct them, and what are the principles while you are correcting this stiff elbow. These are all the things we must know very well, as well as the heterotopic ossification is the one other thing very much commonly seen in this, and commonly you will get the questions for the myocytes ossificans, which is one of the heterotopic ossifications. So with this brief introduction, just I want to start my talk. So first thing is a historical perspective. So Hippocrates in So this is the historical perspective. This elbow stiffness was identified in the Hippocrates era. It is 400 BC. So Hippocrates told that it is the complication of elbow trauma. So the trauma is the main cause for this elbow stiffness. After 2000 years, the Galen first coined the name ankylosing, that is the stiff elbow. And after that, in the same era, Ambrose Paré is the French surgeon first recognized the role of early mobilization in the treatment of stiff elbow. Then 19th century is revolutionized the treatment of stiff elbow by identifying that anesthesia and antisepsis and in X-rays were invented in that particular era. So then Lamberty and William Lane, they advised the elbow trauma, once you fix it, then you can mobilize very early, then you can prevent the stiffness. So Alvin Lambert coined the term osteosynthesis, who is the pioneer for the internal fixation that led us to the 21st century, which makes that all the elbow stiffness can be corrected with the early recognition and early fixation and early mobilization. The end result will be good. So one of our country surgeon, the great Dr. Bhattacharya sir, who has one of the part of this treatment modalities, he has published a paper in the 1964 regarding the elbow arthrolysis by the posterior approach, and he has his own treatment protocols, and he has given a good results with that particular protocol. So with this, you can see this picture in the robo. You can see this joint, elbow joint, that everybody tell about this elbow joint as a golden joint. Why? Because without that particular elbow joint, the reach of the hand, it cannot reach the particular organ, particular area. So you can see this eating, combing hair, and while taking the prasad, there is a particular action, particular elbow range of movements are there. And when you want to reach your bum, is also it needs particular range of movement. To reach the bum, it needs at least 30 degrees of extension. To reach the foot, when you want to take it, it needs at least 130 degrees of flexion. And to reach the hair combing, it needs at least 110 degrees or 90 degrees. And to give the prasada, it needs pronation and supination in both the directions. While the person is taking the prasada, it needs supination. The person is giving prasada, it needs pronation. So all these actions are very much required when treating the stiff elbow. And of all apart from this, you can see this crooked hand. It gives cosmetic problems as well. So stiff elbow is a problem of functional as well as it is a cosmetic issue. So you have to treat them in a perfect way. So normal range of elbow function is, elbow movement is 0 degrees to 145 degrees. In all these functions, from 30 degrees to 130 degrees, flexion and the extension arc is required. And the pronation arc minimum is 50 to 50. 50 degrees pronation and 50 degrees supination to have minimum activities of daily living. So that's why this is called as from 30 to 130 degrees of flexion arc and 50 degrees pronation and 50 degrees supination. It is called as a functional arc. Every person must have this critical functional arc to have the activities of daily living. So any total elbow range of function, if the 50% of loss of the elbow range of motion is there, then automatically it leads to the 90% loss of the elbow function. So see, this is a highly critical joint which needs a perfect range of motion to have the daily activities. So what is the purpose of this elbow? It positions the hand within the volume of sphere centered at the shoulder joint. This is important. Volume of the sphere. Any volume of that particular sphere, if you want to reach it, the elbow function must be there. So loss of function or of elbow from 30 degrees to 130 degrees and 50 degrees pronation and 50 degrees supination. If there is a loss of function is there, then it is called as stiff elbow. Stiff elbow defined is this. And the stiff elbow can be, it is acute and subacute and chronic. If that this is stiff elbow is persisting for the past 6 weeks, 6 months, then it is called as, it is chronic stiff elbow. So most of the times, if the elbow stiffness is less than 6 months, you can try conservative management. If it is more than 6 months, it is better to try for the operative management. The 6 months given period will decide the conservative or operative. So before going to this management, you should understand what is the functional anatomy of the elbow joint. So this is a very crucial thing to understand this stiff elbow. So in the functional anatomy, you will see that there are static stabilizers and the dynamic stabilizers and the secondary stabilizers. Of all this, the static stabilizers are the most important thing and which are supported by the dynamic and the secondary stabilizers. So static stabilizers is the bony architecture. It is hinge joint and highly congruent and highly conformative and it is having a medial column and a lateral column. This medial column is medial pillar by the medial trochlea and olecranon, and lateral column is constitutes with the capitulum and the radial head. And these bony structure is supported with the capsule. This capsule is occupying both the radiohumeral joint and the ulnohumeral joint and the superior radioulnar joint. All these three joints are having within one capsule. This is the important thing. Any function is deranged in any part of this area that can affect all the three joints. So anterior part of the capsule is stronger than the posterior part of the capsule. This is another important point to be remembered. And these are supported with the collaterals, that is the medial collateral ligament and lateral collateral ligament, which are attached to the ulna and attached to the medial epicondyle to ulna and the lateral epicondyle to ulna. And another importantly, the anatomy, if you see the radial head, it is 11 degrees angulated towards lateral side. And if you see the olecranon, this is 5 to 10 degrees angulated towards the medial side. That means the two hands are supporting entire lifting it, entire both the columns, lateral column and medial column. And you see this here, there is a medial collateral ligament and lateral collateral ligament. Entire ulnohumeral joint stability is totally maintained by the medial collateral ligament and lateral collateral ligament. Any derange in this, that will disturb the biomechanics at the elbow joint, and abnormal forces will be transmitted over the articular surfaces. Those abnormal forces will lead to the osteoarthritis. So collateral ligaments integrity is the very, very important thing in the elbow stiffness. And next one is this bony structure. You can see this. The shaft condylar axis, the condylar articulating condylar axis is 30 degrees anteriorly oriented. So because of this 30 degrees anteriorly oriented, then patient can have flexion up to 150 degrees and 145 degrees of the flexion can be possible. Suppose this condylar axis is shifted straight. It is a straight axis. If there is no 30 degrees anteriorly angulated condylar axis, you will lose the movement of the flexion of the elbow joint. It will come to up to only 90 to 100 degrees of flexion. So this anatomical principles is very important. We must remember this. And you can see this in the radiologically also, you can see that it is a shaft condylar axis. It is 30 degrees. Always you must maintain this. Otherwise, this is one of the cause for the stiffness. So later on, this is the collateral ligaments we must discuss about this. If you see this, lateral ulnar collateral ligament is situated on the lateral side. This ulnar collateral ligament is isometrically situated. This isometrically situated means this length won't change in any movement of the elbow. So this is the important point we must remember. The length of the lateral collateral ligament is always constant, both in extension, in flexion. So this prevents the varus stress, and this prevents the external rotation. And we come to the medial collateral ligament. This medial collateral ligament is having posterior band, transverse band, and anterior band. This anterior band of the medial collateral ligament is very important structure to prevent the valgus force. Valgus force. This anterior band. This band, anterior medial collateral ligament, is isometrically located. That means it won't change in the both flexion and extension its length. But if you take this posterior medial oblique ligament, this is medial collateral ligament. This is a fan-shaped ligament, and this ligament will change its length during flexion from 60 to 120 degrees. If you do the flexion, this ligament length will change. It increases up to 9 millimeters. Suppose this ligament becomes stiff or fibrotic, then there is no lengthening of this particular ligament while doing the flexion. So that leads to the flexion deficit if it is fibrosed. Then come to the dynamic structures. It is the biceps and the triceps. Any elbow motion, it needs a reciprocal relaxation of the opposite muscle. Suppose you want to do the flexion. Once biceps is contracting, automatically this triceps must relax. If the triceps is contracting, biceps must relax. Then only you will get a flexion extension movements. Suppose in any neuromuscular disorders like CP, cerebral palsy, and polio, and in the per se muscular fibrosis, any injury to the muscle of the biceps or triceps, they go into the fibrosis. Then there won't be any reciprocal relaxation. That ultimately leads to the fibrosis and stricture and loss of motion in that particular area, opposite direction. Then comes to this picture. So you can see the humeral articulation, ulno-humeral articulation. It is a very tight bond. And if you see exactly in the mid-sagittal section, if you see this, always this articulation is in the middle of this particular circle. So it is 360 degrees. This articulation always 180 degrees. Any fracture of the cornoid, any fracture of the olecranon, that leads to the instability, and the less amount of articulation that leads to the instability. This is anteriorly, this brachialis is the one of the important muscle that is called functional muscle of the elbow joint. Functional muscle of the elbow joint, crucial muscle, and this entire muscular part is highly vascular, and it is attached to the maximum area of the humerus anteriorly. And this muscular part, not only there, it covers the anterior part of the elbow joint, and this inserts 1 centimeter below the olecranon cornoid process. 1 centimeter below that. There is no much tendinous part. Any injury to this muscle that leads to the hematoma, and that hematoma leads to the fibrosis, and that fibrosis leads to the contracture. And posteriorly, that is the triceps that is attached here. And triceps is also, once it is injured, then that contraction leads to the defective things. And this articulation and brachialis and the triceps, these are anterior pillars. The mediolateral pillars are medial collateral ligament and lateral collateral ligament, but anteriorly it is the muscular dynamic force is controlling anteriorly. So in a nutshell, the elbow stability is maintained by the primary, it is the ulnar-humeral articulation by the anterior ulnar collateral ligament and lateral ulnar collateral ligament. And secondary stabilizers are radiohumeral articulation and the pronator flexor muscles also that contribute, and extensor tendons also that contribute on the lateral side. So this anatomical articulation, I have given that the anterior angulation of the condylar axis, if it is changed, the total elbow flexion will be changed. That is restricted. So ultimately, final thing is The collateral ligament stability is the very, very important, crucial to decrease the joint reaction forces. If the joint reaction forces are more when there's instability is there, that instability leads to the pain. That pain leads to the muscular spasticity. That muscular spasticity indirectly leads to the stiffness. So all are interrelated: instability, pain, and stiffness. So what are the causes for this? So there are traumatic causes and atraumatic causes. By knowing these causes in the examination, you can able to elicit better history. So if the patient says elbow trauma, trauma means all intra-articular fractures and extra-articular fractures can lead to the stiffness. There is a malunion and non-union of these fractures also can lead to the stiffness of the elbow joint. And you should ask for the head injury. So a head injury leads to the heterotopic ossification. That's why you must take that. And burns leads to the soft tissue contracture, as well as burns is one of the contributing factor for the heterotopic ossification. And you should, heterotopic ossification per se, even a massage, simple massage can produce heterotopic ossification because of the trauma. Any bleed can produce the heterotopic ossification. And post-surgical. So once you are operated, if you are immobilizing this particular elbow joint for a prolonged period, there is a study, it is proven that if you immobilize the elbow joint more than 3 weeks, the results will be fall down up to 20 to 30%. If you mobilize early, the results will go up to 70 to 80%. So immobilization and post-surgical early mobilization, those are all very important. And prolonged immobilization. So atraumatic causes, you can see that congenital, it is arthrogryposis multiplex congenita. There is a webbing at the joint area that because of the soft tissue, and the congenital radial head dislocation is also one of the causes for the congenital. And osteoarthritis is because of the, most of the times it is only constituting only 2%. This osteoarthritis is because of overuse and lateral elbow strains, and sports people like all racket using sports personnel, most of the times they have this osteoarthritis. And rheumatoid arthritis, this is one of the common thing exam, you will see this, rheumatoid. And other is hemophilic arthritis and infective arthritis. And lastly, it is the neuromuscular problem, CP and polio. So when you take history, you should cover all these things. Then what is contracture? It means it is possible to do the further extension, but there is no flexion. Just like if you see the abduction deformity, there is no adduction, but further abduction is possible at the hip joint. Just like that, in elbow, if you say that it is an extension contracture, there is no flexion, but further extension is possible. If it is the flexion contracture, it means there is no extension, opposite movement, you won't get it, and flexion is possible. Ankylosis means there is no movement, it is a fixed deformity. It is a fixed deformity. But all this stiffness, it is directly proportional to the initial trauma. So that's why it is very important to ask the mechanism of injury and the treatment perspective in these elbow injuries. So stiff elbow is directly proportional to the severity of the initial trauma. So of this, flexion deformity is more common in the elbow joint. Why? Why this flexion deformity is more common? So if you know this, there is a thick anterior capsule and anterior angulation of the condylar axis is there. And there are collateral ligaments are anteriorly oriented. They are not posteriorly oriented. So that's why the flexion deformity is more common anteriorly. And the flexors are more powerful than the extensors. And the position of ease of the elbow joint is 30 to 40 degrees flexion. Once injury is there, it will accommodate more amount of fluid within that particular joint. So that flexion deformity, that's why it is more common than the extension deformity. But extension deformity correction is very difficult, and the flexion deformity is always, correction is easy, but every attempt should be made to get the more flexion than the more extension. So if you want to get the more extension, it is not that much useful, but if you get the more flexion, it is functionally, it is more rewarding. So what is the pathogenesis for this? This is a very important slide for the student. In the examination, definitely it gives you a very good impression. So any injury, it will mediate the inflammatory process. This inflammatory process are mediated by the cytokines, that is IL-1 and IL-6 and TNF-alpha. And TNF alpha and these will stimulate the fibroblasts. These fibroblasts are further stimulated, transformed into myofibroblasts by the transforming growth factor. So these myofibroblasts are having a smooth muscle actin, that is more powerful contractile element, that is making this fibroblasts into a defective collagen formation. And defective collagen formation directly leads to the arthrofibrosis. This is happening, observed in the anterior part of the anterior capsule of the shoulder joint, elbow joint. Then they observed in the capsule, anterior part of the capsule, full of mast cells. These mast cells are neuropeptide related, and this releases, this mast cell granules will release profibrotic cytokines. This profibrotic cytokines will lead to the arthrofibrosis. And in the matrix, there is a metalloproteases and proteoglycans. If they are reduced, then that will lead to the increased scar formation, because scar remodeling doesn't occur if the metalloproteases are less. Then that will also lead to the arthrofibrosis. And in the joint, the lubrication is very important. That is maintained by the lubricin. This lubricin is defective after injury, so that leads to the arthrofibrosis. And all these people are more genetically predisposed. All the elbow injuries people, they won't get the stiffness, but there are genetical predisposition is there. That is SMAD4 gene. That gene will increase the synthesis of transforming growth factor, that indirectly increases the myofibroblasts, that leads to the arthrofibrosis. So these are all microcellular level, molecular level analysis that leads to the fibrosis, arthrofibrosis. Then what is the treatment? If you apply the gene therapy can lead to decrease in the SMAD4, and by doing so, you can reduce the tumor growth factor. And infliximab, it is a monoclonal antibody that will act over the TNF alpha, that can reduce the arthrofibrosis. And nowadays, there is a collagenase. So commonly it is used in the dependence contracture. That collagenase enzyme that can be periarticular area, if you can inject it, that can reduce the stiffness of the joint. And mast cells can be controlled with a ketotifen drug, so that can decrease the mast cells, and that can indirectly reduce the arthrofibrosis. And last one is the relaxin. It is commonly in the pregnancy, there is a ligamentous relaxation is there. That is because of the relaxin 2. All these are all under trials. If recent advances question comes, definitely these things will add, and these things will be useful. This relaxin, they are trying into the intra-articular injection, and they are observing that there is a decreased stiffness of the particular elbow joint. So this is recent advances. Then any pathology you should understand, and you should diagnose it, and you should have a proper approach. If you want to have a proper approach, it needs classification. So classifications for the stiff elbow, you see that case classification, Mansett and Murray, and Jupiter and Murray classification, and Jiang-Sung, this is the recent one. This is 2020. It is a pathological classification. Of all these classifications before Jiang-Sung, they never addressed about the forearm rotation arc, that is supination pronation, but only Jiang-Sung advised involved that keeps that forearm rotation acts. But these are all collectively useful to identify the cause and to plan your surgery. So that's why you must know all these classifications. Case classification is the anatomical classification. There are 5 types are there. And Mansett and Murray, this is the range of motion, that is less than 30 degrees of motion arc is there. That is the severe one. I will explain later on. So you can see this. It is a flexion extension arc you should mention, and pronation supination arc you should mention. And severity, this is Mansett range of motion. That is less than 30 degrees of arc is there. It is severe deformity. If it is the less than 60 degrees, it is a severe deformity. If it is less than 90 degrees of arc, it is the moderate. If it is more than 90 degrees of arc, it is there. It is the minimal. What is the minimum required functional arc? It is 100 degrees. If you are reaching that level, more than 90 means it is a good one. And etiological also you can plan it. It is a post-traumatic and a micro-traumatic and arthritic. And other thing is, it is a arthrofibrosis, and here it is an infective. And another prognostically, you can classify that this is classified by the O'Driscoll and Jupiter, simple stiff elbow and complex stiff elbow. Why this is designed is the simple stiff elbow can be managed with arthroscopically and conservative management. And a complex stiff elbow definitely needs open procedure. This is the main, it will decide whether it is to be treated conservatively or arthroscopically. All these, you can see this, there is a moderate contracture and no minimal prior surgery should not be there. And there is no anterior transposition or any surgery over the ulna now. And there is no internal fixation. Any metal should not be there. And there should not be any heterotopic ossification. And bony anatomy should be normal. All these findings are perfectly matching to the rheumatoid arthritis and osteoarthritis and simple lesions. But complex lesions, severe stiffness and multiple prior surgeries and ulnar nerve transposition is done and prior internal fixation and significant heterotopic ossification and distorted bony anatomy. All these will need a perfect correction to get the early range of motion. So this needs open procedure. But what are the things to be corrected? That is decided by the Murray. Murray classification is highly acceptable and functional. And this is the most common one everybody will follow because it is simple. What are the intrinsic pathologies? Intrinsic means anything that is inside the capsule, those are all intrinsic pathologies. And anything outside the capsule, that is called extrinsic pathologies. What are the intrinsic pathologies? Articular incongruency and intra-articular adhesions and cartilage damage and loose bodies and osteophytes and crowded fossa, that is olecranon fossa and coronoid fossa and radial fossa. If they are crowded like this, that's a bony block obstruction will be there. This is the loose body and a deformed articular joint. And what are the extrinsic possibilities? It is the capsular. From the skin, you can go up to the capsule. It is a skin contracture, it is the muscle contracture, it is the ligamentous instability, and outside neuropathy, ulnar nerve involvement, and outside heterotopic ossification. These are all external. But you take any stiff elbow, it is always mixture of both intrinsic and extrinsic. So that's why most of the times, all these procedures are open rather than orthoscopic. So the newer classification is the pathological classification. This depends on the elbow flexion and extension and forearm rotation. This elbow flexion EF1, EF2, EF3 and EF4, this one is the tethers. Tethers means it is the soft tissue problem and blocks means it is the bony problem. The grade 1 is tethers only. Grade 2 tethers with blocks, that means bone both. Third one is the articular malformation. And last one is the bony ankylosis because of the heterotopic ossification. And you remember always this articular malformation is the most dreaded one and very difficult to treat. And always it will give the bad results. And forearm rotations, it is a contracture alone and radial head malunion fractures and non-union. This will give you the best results. But last one is the proximal radial ulnar synostosis. This will give the bad result. So EF3 and FR3, these two will give a bad results. You should be very careful in this. Remaining all will give you the good results. So what is tether? It is a tensile resistant to motion in opposite direction with soft endpoint. So if it is a soft tissue problem, if you stretch it, suppose elbow is fixed in the flexion, if you try to extend it, opposite direction, extend it, you will get a yield. Yield means, suppose you say the ACL, when you are testing it, Latchman, you say that there is a soft endpoint. Once ACL is ruptured, there is giving way. It is a soft endpoint. Just like that, the soft tissue contracture will give you the soft endpoint and bony block will give you the hard endpoint. It is an abrupt block. It's a suddenly it blocks it. So abrupt block is always indicative of hard endpoint and some stretch is good that will tell you it is a soft endpoint. It is that this understanding is very important. Soft tissue contractures can be treated conservatively and bony block lesions must be operated. So that is the importance of clinically you should identify. In the examination, you should tell this point, whether it is a soft endpoint or it is a hard endpoint. So what are the soft tissue contractures and what are the bony parts, tethers? So tethers, you take that always opposite. Suppose it is a tethers of the It is the flexion. So once there is a flexion loss means it is the opposite soft tissues are contracted. That means flexion means you are going towards anteriorly. So that means opposite posteriorly triceps scarring, posterior capsular scarring, and posterior medial transverse band of the medial collateral ligament. Those are damaged. If the extension loss means it is skin contractures in the anteriorly, it is biceps scarring and anterior capsular scarring, and the anterior band of the medial collateral ligament is. And the blocks are in the same side direction. Suppose if you say the flexion block means it is in the anteriorly located. That is a heterotopic ossification. If the extension block means it is the posteriorly located. So this understanding is important while correcting the stiff elbow. So what are the things? It is the easy way to remember that 4 things front and 4 things back. So 4 things front means you can see that capsule anteriorly and posteriorly, and creating the olecranon and radial and cornoid fossa, olecranon fossa posterior and radial and cornoid fossa anterior, and removing the loose bodies and osteophytes both anterior and posterior, and tenolysis of the triceps posterior and brachialis anterior. So 4 front and 4 back. If you can remember this, this is a very easy thing to do the surgical arthrolysis. And the excision of the heterotopic ossification and extraarticular soft tissue contractures is also important. Never ever forget this examination of the ulnar nerve. Why? Because ulnar nerve per se, impingement or irritation of the ulnar nerve will lead to the spasm, and ultimately it leads to the stiffness of the posterior medial oblique ligament and fibrosis of the posterior medial oblique ligament. Ultimately, it leads to the flexion contracture. If you don't relieve it, this is commonly seen in the olecranon fractures. So now the case comes, how do you approach, how do you take the history? So first you have to take the age of the patient, sex of the patient, occupation, and handedness, dominance of the hand. You must mention these things first. Why age is important? The children bear with the deformity very well, but adults never bear with that particular deformity. They are not good. And female patients are poor patients to have a good results. And the occupation, drilling workers and all these people are having a micro trauma to the elbow joint, and they can get the osteoarthritis of that elbow joint. So that's why you should ask for the occupation for the cause of elbow stiffness. And at the same time, occupation will give you whether this patient needs what type of modality of the treatment. And handedness, right-handed dominance or left-handed dominance will give you that which one is the most important and how to treat them. Then history, you should always ask for treatment history and duration of immobilization and how many manipulations are taking place in the initial after trauma. So more than 2 manipulations is not acceptable, and massage is also not acceptable. Any surgeries, multiple surgeries within 7 to 14 days, multiple surgeries, that leads to the stiffness. And the mechanism of injury, the more violence, the more stiffness. And history of head injury and cervical spine, that leads to the heterotopic ossification. And a history of ankylosing spondylitis and idiopathic hyperostosis, that leads to the again heterotopic ossification. And a history of infections and history of rheumatoid arthritis and bleeding disorders. Always you ask for history of rheumatoid arthritis. If case comes, most of the times elbow rheumatoid arthritis is having wrist arthritis, 80% of the people, and 70% of the people always it is having opposite elbow is also involved. So in rheumatoid arthritis, you never forget to examine the cervical spine also. And spasticity, this is because of the neuromuscular disorder, whether it is CP and brain injury also can lead to the spasticity of the muscle. I told you that reciprocal relaxation is very much essential to have the good movement at the elbow joint. And the deformity, orthographos is directly from the congenital. And any crepitus heard during the movements, the sound, sometimes patient may complaining of sounds that indirectly speaks of it is an intra-articular pathology. And medical history is also important, diabetes and BMI. Diabetes patients will have bad results, and more BMI also will have bad results due to poor rehabilitation. And the personal history, this is the one that will decide whether what surgery is to be taken. It is a vocational and recreational and pursuits and high expectancy of the results from the patient. Those patients are bad candidates for the surgery. So in these surgeries, suppose patient is having 90 degrees of the stiffness, then loss of arc. Only you can regain half of this loss of arc, then that will give you a good functional thing. So any person is having high expectations, those are bad candidates. So ultimately, loss of function, deformity, you have to see it, and the cosmosis, you have to correct it, and pain. So of all this, pain is the very important thing. You should analyze this. So what is the clinical evaluation? Pain at terminal degrees. Initially, there is no pain at rest, and the movement arc, certain movement arc is painless. That means terminal degrees, if you are having pain, it is a mechanical block. Either it is a loose bodies or it is a osteophytes or impinging over that. And pain continues throughout the arc of the motion. That indirectly speaks of arthritis and rheumatoid arthritis, example, osteoarthritis. And pain at rest, it is an infection. Pain at rest is the very important thing. If pain at rest says, that means it is high chances of infection, especially in the post-surgical case. Especially in the post-surgical case. And pain associated with crepitus, indirectly it is giving you clue. It is either it is arthritis or synovitis or it is an osteochondral defect. And pain associated with locking, that means there are free loose bodies are there. So synovial chondromatosis, any osteochondral fractures, any loose bodies within that. Never forget, it is an electric shock-like pain along the narrow distribution, ulnar neuritis, which is a very important thing. That thing you should elicit always. So what are the things you should examine for the ulnar now? So always see for the encroaches and always ask for the pinch. How is it? And see the sensitive distribution. Any wasting of the muscles, you should search for the Tinel sign and always feel over the cubital tunnel for the tenderness. Even the patient is not saying anything, but tenderness over the cubital tunnel, that means it is an important clinical sign you have to tackle with the ulnar now. Then you have to evaluate the three bony points. So this will give you the clue whether it is an intercondylar fracture, whether it is a dislocation, or it is a fracture dislocation, or it is anything other than this. So this is three bony points orientation. Whether it is an articular problem or extra articular problem, that will decide by these three bony points. For example, you can say that this is an elbow dislocation. There is a prominent triceps it is seen, and three bony point relation is varied. This is the malunited supracondylar fracture. The three bony points are always retained, but rotation of the three bony points is seen. It is the lateral condyle fracture. You can see that intercondylar distance is widened, and from the olecranon tip to the lateral condyle distance is increased. So like that, we should able to see what is the type of fracture, what is the thing you can easily identify and you can diagnose. So movements, always you ask for the active movements first, then you ask for the passive movements. When you do the active movements, if the patient can able to do the active movements, means the neuromusculo-tendinous junction is intact. That means neurology is intact. Neurology is intact. So to identify that, active movements and passive movements, to identify whether it is a soft tissue contracture or it is a bony defect. In the soft endpoint is there, we already discussed, it is because of the soft tissue problem. If it is the bony block, abrupt sudden block, means it is the hard endpoint. It is bony block. This needs a surgical correction. This needs a trial of conservative management. Always mention about the range of motion. Arc you should mention, whether it is from the 30 degrees to 70 degrees and free and all these movements. And always mention whether this movement is associated with pain or not. And always assess whether this movement is associated with crepitus or not. All these 3 points you should mention in the examination. And arm length and forearm length is also important to identify what is the type of the fracture. In the supracondylar fracture, arm length is decreased and forearm length is normal. And in like that, arm length and forearm length is very important. You have to read about that. And forearm girth and arm girth, that will tell you wasting of the forearm muscles and triceps and biceps. Any wasting of that particular muscle, when you are operating it, the physical rehabilitation is very, very difficult. Very, very difficult. So in those cases, to tell the prognosis, the forearm length and arm girth is important in these cases. So how do you tell the diagnosis? So in the examination, you should tell a 40 years age you are mentioning, old left-handed means you are mentioning of the dominant hand, and female patient, and you are mentioning about the vena instructor, that means you are telling the occupation, and with a post-traumatic whether it is a post-traumatic or non-traumatic stiffness, you are mentioning it. And you have to tell the duration, whether it is a more than 6 months or less than 6 months. That will tell you about the treatment options. And the motion of work, how much it is, 40 degrees to 90 degrees. And with difficulty in performing activities of daily living and her profession difficulty. And last but not the least, it is the cosmetic concern. So in the diagnosis, you should mention all these things. That will clearly tell you your approach and your management. So how do you proceed for this? Then examiner will ask you, how do you proceed? Then immediately you should tell that I want to take the X-ray and I want to do the relevant investigations in these cases. What is the relevant investigation? X-ray. In X-ray, you take AP and lateral view of the elbow joint. Always include the wrist joint. This is the point I am stressing on this. And you have to take the internal rotation and external rotation views. Sometimes examination under fluoroscopy will tell you where is the block. Is it really that block is corresponding to any bony block? And ultrasound, CT scan, MRI, and laboratory tests also important. CRP, TCD, CSR will tell you about the infection, and BTCT and APTT will tell you about the hemophilic problems. And alkaline phosphatase and urine, other investigations will tell you about the any myositis or hypertrophic hospital. And lastly, if the patient is having tender pain at rest, never ever forget to do the aspiration of the particular joint, because you are suspecting infection. You can send it for culture sensitivity and you can identify the bug. Aspiration is also one of the important investigation. So when you ask for X-ray, patient is having 45 degrees flexion contracture. If you take the X-ray elbow, you could not able to see the anything at the joint line, because joint line visibility is the most important thing in stiff elbow. Once a joint line is clearly visible, that means you are thinking that it is an extra-articular, and this intra-articular problem is less chances. I already in the initial classification, I told you any intra-articular problems will give you bad result, extra-articular problems will give you good result. So to identify that, in the flexion deformity, it won't give you a perfect AP view. So that's why you have to take the transverse images. Transverse images means you have to take the X-ray of the humerus at right angles to that, and you have to take the X-ray of the ulna at right angles to that at the elbow joint. Then you can able to visualize entire length of the ulna and radius, and you can able to appreciate the radiohumeral joint and ulnohumeral joint very clearly. So observation of the whether the presence of joint line is very, very important. Then come to the CT. CT is the very important tool. Never forget to take the CT. It will identify the what are the malunions, non-unions, and what are the hypertrophic ossification is there and heterotrophic ossification is there. Any osteophytes, any loose bodies, and what about the coronoid fossa and the radial fossa and olecranon fossa? Any impinging is there. These are all simply you have to take all the cuts. At the ulnohumeral joint, you have to take one cut, and radiohumeral joint, you have to take one cut. And never forget mid-sagittal section, that will give you about the osteophytes that are impinging over the fossas. And in the coronal views, you can able to appreciate the articulation and irregularity of the articulations. And at the coronal area, you must take the fossa level. You should take that whether the fossa is blocked or not. And last section is at the superior radioulnar joint to know that very forearm rotations are blocked. Any osteophytes are there, and what is the articulation between the superior radioulnar joint. So these are the cuts that are very much necessary when you're dealing with the stiff elbow by taking CT scan. Another important in the mid-sagittal section, so if you can see the osteophytes that are present in the coronal fossa and the coronoid fossa, you can calculate the angles from the center of the condylar axis. So what are the angles and what are the angle osteophyte is there at the coronoid? If you mix all these angles, those angles are giving indirectly this much of range of motion you can get post-operatively. So CT is very important to tell the patient how much of range of flexion or how much of range of extension you can get. You can calculate on the CT findings. Then ultrasound. This is the cheap investigation, but it is very useful in myositis ossificans. It will detect the myositis ossificans very early, and any muscle injuries, any ligamentous injuries also it will detect. And most importantly, even MRI cannot detect, but ultrasound can detect ulnar nerve dynamically. The movement of the ulnar nerve, how much movement is there, that will be any movement of the ulnar nerve that gives the irritation, and that will leads to the stiffness of the elbow joint. So how much is the specificity? With ultrasound, you can get the specificity of collateral injuries, muscle injuries, ulnar nerve. Specificity is 90, and it is equal to MRI in best hands. If a good ultrasound personnel is there, then it is no need to go for MRI. Then what is the importance of MRI? It will detect the articular cartilage problems, and the neurovascular anatomy it will tell you. So what is the distance of the neurovascular structures are related with the bony blocks. When you are operating, you will be careful while reaching that particular area. And ligaments, whether they are partially injured or completely torn, that will give you with the ligaments. And a myosite is also you can able to detect with this MRI. So then how do you plan for this? Your planning of treatment depends on the clinical findings and radiological findings and the requirements of the patient. So all these three, you should take it into consideration, then you plan. And the duration of the stiffness. If it is less than 6 months, you can try conservative management. If it is more than 6 months, you have to go for operative management. If it is a bony block, always operative management. If it is a soft tissue contracture, you can try for the conservative management. So there are various methods. So first, conservative management indications are, it is a minimal contracture. That means it is 90 degrees flexion arc should be there, or 60 degrees of flexion arc should be there. Then only you can try for this one. And the duration should be less than 6 months. No osseous reason for the stiffness. And modalities used is static splinting and static progressive splinting and dynamic splinting. So static splinting, once it is corrected, you want to maintain that particular corrected thing, you use static splinting. The static dynamic splinting is, it is connected with the spring loaded at this area, and spring loaded that is connected. Yes. So very sorry, there is a net issue, that's why. So, then what is dynamic splinting? In the dynamic splinting, where spring is connected to the splint and it is continuously stretching that particular joint. Once it is continuously stretching, that particular muscles are stretched continuously, and it will generate pain. And most of the times, because of the generation of the pain, the central nervous system will act and it will produce spasticity of that particular opposite muscles. Then that leads to the contracture again. So bad results will come with the dynamic splinting. So then what is static progressive splinting? Routinely what we follow is the static progressive splinting. This is gradual stretching that particular muscle. That means we are deceiving it, that particular muscle, not to get the spasm. So you stretch the elbow joint with the turnbuckle splinter. This is turning of this one, that will increase the gradual stretching. Once you gradually stretch till you get the pain, there you have to stop it. So then once you stop it there, that particular muscle think that it is not stretching and it relaxes. That means it is a reciprocal relaxation is very, very important. Once the biceps is stretching, automatically the triceps should contract. So like that, gradually you stretch the biceps, then automatically the triceps will contract and you will regain that particular movement. To relax that particular contracted muscle, you have to use this turnbuckle split. So the principle behind this is, it is a stress relaxation and reciprocal relaxation of the muscles. So this principle you should tell in the exam. What is the principle behind this turnbuckle splint? What is this static progressive splinting? So another thing is manipulation under anesthesia. Nowadays they are not doing manipulation under anesthesia. Most of the times they will get bad results with this. How much pressure we are applying and how much stress on the articular cartilage, that leads to the further stiffness. That's why this is discarded. And the botulinum toxin is spasticity, people. If you want to try to relax, get the extension, you have to give it in the flexors. And if you want to get the flexion, you have to give it in the extensors. And continuous passive motion after surgery, after relieving Some people will advise continuous passive motion. Because of this continuous passive motion, sometimes you will get pseudomas, hematomas, and sometimes it will give the negative results. Nowadays, some people are following and some people are not following with this. And after conservative, it is the surgical treatment. The surgical treatment is arthroscopic arthrolysis. This arthroscopic arthrolysis means, arthroscopy means you are going inside the joint. That means inside the capsule. That means whatever the problem inside the capsule only you can tackle with arthroscope. Extra articular things you cannot tackle. So that's why simple stiff and minimal prior surgery, all the things, this here, the Jupiter and O'Driscoll classification will be helpful, whether you have to go to through the arthroscopic or open procedure. And in stiff elbow, you will surprise that in the stiff elbow, you will get only joint space will accommodate only 6. Normally, the joint space is up to 25 to 30 ml. So here it is only accommodating only 6 ml, and all the neurovascular structures are very close to the capsule. So while you are passing your scope, there are endangering all the neurovascular structures. Once you must remember, this arthroscopic removal of all loose bodies and osteophytes and debridement and capsule release, all these are all called as osteocapsular arthroplasty. This name given by the O'Driscoll. And arthroscopy is absolute contraindication once the patient is having anterior transposition of the nerve. This is an important thing you should remember. And open arthrolysis is by the 4 approaches. Laterally you can approach, and medially you can approach, posterior and anterior. Lateral approach when you want to regain the extension, medial approach when you want to regain the flexion. Posterior is the extensile approach where you can do the interpositional arthroplasty and total elbow arthroplasty. The posterior approach is very much useful, but anterior it is very rarely used. Only it is used for extensive myositis in the anteriorly located. So what is the lateral approach? This is commonly used and most useful approach. This is called column approach. This is lateral column procedure described by the Murray. You have to give it the Cocker incision and you go through that, and extensor carpi radialis longus and extensor carpi radialis brevis, through that approach you have to go. But the advantage of this is it is extra capsular lesions. You can able to address all the things, and you can go to the lift the brachialis and you can resect the all anterior capsule, and you can address the radial head lesions also with this approach. This is the advantage. And posteriorly also you can go, and posteriorly also you can release the olecranon fossa and olecranon osteophytes. So you can address both anterior and posterior, but only drawback is you cannot address on the medial side, which is ulnar nerve and posterior medial oblique ligament. You cannot address with this. So if the patient is not getting flexion, so that means you have to go again onto the medial side and you have to release this. So this medial approach is called a medial over the top technique by the Mott procedure by the Hotchkiss. It is described, and give a longitudinal bigger incision in the medial side, and this will give you the flexor pronator group along with the brachialis. You should elevate from that area. Before doing that, you have to dissect the ulnar nerve and you have to release it, and then you can go anteriorly and you can release the capsule. And advantage with this, you can address the ulnar nerve and you can address the posteromedial oblique ligament, which is responsible for the lack of flexion. If the patient is not having flexion, always you must approach from the medial side. This is very important. What is the advantage of these column procedures? So anterior, posterior, coronoid and olecranon can be exposed, and incision is neutral axis. That's why there is less tension over the incisions. Wound healing is good, and the stability is well maintained because you are retaining the collaterals. So that's why rehabilitation will be very good, and it can be combined. Whenever you want to address both the sides, it can be combined. 2 incisions you can able to give it, and retaining the flexor pronator and extensor supinator groups. That means a good physiotherapy can be possible with this procedure. So that's why most of the elbow stiffness with the bony blocking procedures, they are doing with the medial column procedure and lateral column procedure. So last one is the surgery through the posterior approach. In the posterior approach, there are various approaches are there. Campbell's approach, Brian Murray approach, triceps sparing approach, and trap approach. All these approaches are done for the total elbow orthoplasty and interposition orthoplasty and the chronic stiff elbows, very chronic, long-standing stiff elbows only can be addressed through this. Where you want to do the dislocation of the joint, only the posterior approach is the best. But the problem with this is it is hematoma formation, seroma formation, and lack of good physiotherapy and triceps ruptures, wound gaping. These are all the possibilities. And delayed ulnar nerve neuropathy can be possible with this. Once delayed ulnar nerve neuropathy, either with arthroscopy or with open procedure, it should be tackled within 2 weeks. This is the important point. It should be tackled within 2 weeks, not to get the bad results. Always you have to do the anterior transposition of the nerve. And Bhattacharya technique, our Indian surgeon technique, this is the ortholysis of the elbow joint. Commonly, this is asked in the exams. This is removal of the capsular contracture and mobilizing the both brachialis and triceps. This is done in the medial and lateral approach, and sometimes some people will do it with the posterior approach as well. And a minimal removal of the blocks. And after removing all these things, release has been done, then you have to inject the hydrocortisone 25 milligrams and 2 to 5 cc of the Hyles you inject in order to prevent the adhesions. So initially you will give it, but after 7 days also you can give the same dose of 25 milligrams of hydrocortisone and 2 to 5 cc of the Hyles. And he quoted very good results, and it is published in the 1964 in the JBJS. And what is the outer bridge in Kawasaki? Very minimal osteophytes. Both coronoid fossa and olecranon fossa is filled with the osteophytes. And this is the simple procedure that will give you good range of movement. It is outer bridge Kawasaki procedure. It is ingenious operation, and you have to do the fenestration of the olecranon fossa. You make it bigger fossa. You have to remove all the osteophytes around the olecranon fossa. Then you will get full range of movements. So just like this, it will appear after doing this. A big olecranon fossa and coronoid, both are interconnected. And X-fix, where do you use it? And elbow orthoplasty. These are the two things. Interposition and distraction orthoplasty. More than 50% articular cartilage disruption, then it is more than less than 60 years age. That means young people, you have to do it interposition orthoplasty and distraction orthoplasty. And external fixation is to protect the whatever you would have done this interposition orthoplasty and all this. And any joint is narrowing is there you can do the distraction orthoplasty to maintain the joint movements. And total elbow orthoplasty is designed for the stiff elbow more than 60 years. And excision orthoplasty, it is an end-stage procedure where a total elbow failed and the interposition orthoplasty is also failed. There you have to do the excision orthoplasty. So interposition orthoplasty, most of the times you use posterior approach and you do the young patient, and retain bony structure is the most important thing in this. And it is commonly done in the rheumatoid with retained bone structure, and post-traumatic ankylosing also you can do it. And more than 50% cartilage should be damaged. Then only you do the interposition orthoplasty. And the main indication for this is painful joint. So, and painful stiff joint in a younger age group where you cannot do the total elbow orthoplasty. This is the main indication. Contraindications, infection and grossly unstable elbow and congenital ankylosis, it is not suitable. And materials that are used in this interposition orthoplasty, it is by the either dermal grafts or muscular flaps, and you can use the Achilles graft and tensor fascia, you can use it. And synthetics or gel formed membranes are used in this interposition orthoplasty. And results are rewarding in young patients. So that is the external fixator that is applied to the humerus, 1 pin and 2 pins to the ulna, and you can distract it. The distraction should be only 2 to 3 mm, and you can protect the whatever the fascia that is laid down on that distal end of the humerus, that will be protected by this distraction. And you can allow the movement as well as. So this elbow external fixator should be removed after 3 to 4 weeks. So this is how pinch should be there. So and lastly, it is a total elbow orthoplasty. Total elbow orthoplasty is for the intra-articular problems where the gross articular cartilage is destroyed more than 60% and more than 60 years of age and low demand patients. These are the three things where you can do the total elbow arthroplasty. In the total elbow arthroplasty, there are three: unconstrained, semi-constrained, and totally constrained. The bad results are with the totally constrained, and the semi-constrained is the commonly Conrad and Murray process that is commonly used. This is a three-piece, and there is a floppy hinge is there, and anteriorly there is a hinge to protect the humerus. This is the Conrad and Murray. This is commonly used. In the exam, they will ask you, what process do you like to? It is semi-constrained process. And this is unconstrained process. It is to be done. Collateral should be good, and good bone stock must be there. Good bone stock must be there, and this will give you that a good results with uncontrolled. That means collateral intact, good bone stock, all race group people, you can do this unconstrained. So a little word about this heterotopic ossification, because it is very important in the exam. Definitely they will ask you. So this heterotopic ossification is the riddle first described. This can be traumatic and non-traumatic. And formation of mature lamellar bone. This is the word important. Mature lamellar bone in non-osseous tissues. So this myocytic ossificans is one of the heterotopic ossifications. This heterotopic ossificans is seen in the muscles. So that's why it is called myocytic ossificans. Truly speaking, it is a misnomer. But periarticular calcification is the deposition of amorphous. Here you cannot see the any shape. It is amorphous calcification, calcium pyrophosphate in the soft tissue. This is very rare, not that much common in this. But myocytic ossificans, it is traumatic, and heterotopic ossificans is the other. This is an important thing because of the massages, important risk factor. That's why in the history always ask for the massage. This 3% is seen commonly in the pure dislocations, and 5 to 10% is seen with the head injuries. That's why in the history you should ask this. 20% is fracture dislocations, and 80 to 90% may develop heterotopic ossification with head injury with elbow injury. Both the injuries, it is highly prone. So indirectly it says the more the violence, the more risk of the heterotopic ossification. So what are the types of this? It is the myositis ossificans progressiva, myositis ossificans dramatica, myositis ossificans circumscripta, and myositis ossificans paralytica. So in the paralytica, you can see spinal cord injuries, head injuries, and hypoxic brain injuries, encephalopathies. You will get this because of the paralysis, you can get the heterotopic ossification. And in head injuries, it is because of the releasing osteoblastic growth factor. That is the reason why they will develop more bone formation. And the myositis ossificans progressiva is the autosomal dominant disorder. It is a genetically predisposed, and most of these patients will have monophalangeal great toes, and this calcification predominantly in the periscapular area and the peri hip areas, you will see this. And in the soleus, in the Bellarian trances, continuous repetitive trauma of the muscle also can lead to this heterotopic ossification. That is because in the Bellarians, in the soleus muscle, and in the rifleman, you will see in the shoulder muscles, and in the gracilis, you will see in the horse riders. So you remember these things. And what is the pathogenesis? It is the metaplasia inducing agents. And osteogenic precursors are there after trauma or hematoma formation. These precursors are influenced by the metaplasia-induced agents and the permissive environment. And the prostaglandin E2 is another important factor. It is an inflammatory mediator that ultimately leads to the osseous tissue formation. But always remember, it is without periosteum. It always maintains a zonal phenomena. Zonal phenomena means it is an outer cortical shell, highly mature, immature cells and undifferentiated cells, and a highly mitotic area and highly cellular retipia will see in the central part. And later you will see the immature osteoid. Immature osteoid, that means osteoid with chondroid cells. And then you will see the mature osteoid, but it is not mineralized. That is the third layer. So once in the outer layer, mature osteoid with mineralized calcification. So classically in the X-ray, in the outer cortical rim, you will see once it is matured. As long as it is not matured, you won't see the cortical shell here. Then how it is evaluated, clinically how it appears. It is 3 stages are there. One is pseudo-inflammatory stage and pseudo-tumoral stage, and third one is the regression stage. Pseudo-inflammatory stage passes up to 2 to 4 weeks. In this particular area, severe pain, local rise of temperature, diffuse swelling, and loss of movement. This is important. Initially, patient is not having good range of movements. Suddenly, patient says that I am losing movements with local rise of temperature and pain. That means you should get the suspicion always. This is the important classical history. And the pseudo tumor, once it is maturing by the 4 to 8 weeks, by the time 2 months, it is maturing it. Then you will get a painful hard mass and mechanical, but local rise will be temperature will be decreased. If you take the X-ray, you will find the dotted wheel appearance. That means it is a fluffy shadows of that calcification. You will see that. Then in a chronic phase, once it is matured, it is resolution phase. By the time 3 months, it is totally appears, and by the time 6 months, it is resolution will start. That means it is the matured one. In this phase, you will see the painless hard mass, and the mass size will shrink. This is another important classically patient will tell you, and always it will give you the mechanical block. So intensity of the ossification is inversely proportional to the age, and it is directly proportional to the severity of the trauma and the severity of the head injury. Always you must take the head injury history. And what are the differential diagnoses for this? In the initial inflammatory phase, osteomyelitis will come into the differential diagnosis, and osteosarcoma and rhabdomyosarcoma and synovial And the pseudotumoral phase, there is a calcifying hematoma, intramuscular parasites like cysticercosis, and the synovial sarcoma and hemangioma containing fibrillars. These are all will come under differential diagnosis in the phase 2. So differential diagnosis also important. And all these clinical features, and if you take the histological picture once you got the doubt, all these will form give a confusion to the surgeon, a confusion. So whether it is a myositis or osteogenic sarcoma, because the treatment is totally different and prognosis is totally different. So that's why, how do you differentiate? In the exam, definitely they will ask you this question. So calcification is from the periphery to the center maturation. It is centripetally maturation. In osteogenic sarcoma, from the center to the periphery, in the center to the periphery. And always pain is decreasing with the time. But here pain is always increasing with the time in osteogenic sarcoma. And the calcification that commonly seen at the diaphysis location, and it is extending onto the other areas. But here calcification is always starts at the metaphyseal location. And there is no infiltration of the adjacent muscles. Why? Because it is a clear space that is seen between the mass and the adjacent muscles. But infiltration is always seen with the osteogenic sarcoma. That's why you never see the clear space between the muscles and tumor. So this always follows a rule of 3, just like that. Zonation always starts with the 3 weeks. And by the time 3 months, it is at peak. And after from 3 months, another 3 months, it gets matured. And always remember, 1/3 of the people will have spontaneous regression. Spontaneous regression, especially in the children. So that's why whenever there is, you see the ossification, if the mechanical block functional obstruction is not there, it is better to wait in the children. Spontaneous regression will give you, and it will give you the good results. And there is a classification for this. It is a Hastings and Grandman. Radiologically, it is evident, but functionally, it is good. So there is no problem. It is type 1. And type 2, functionally, there is a flexion and extension is limited, but pronation and supination is good. And grade B, it is only supination and pronation is involved, and both the planes are involved. It is type C. And last one is the complete ankylosis. Most commonly, this is seen at the posterolateral aspect of the elbow, and most common in muscles that are involved, it is the brachialis. And anteriorly, if it is involved, it starts from the humerus, and always most of the times it goes to the radius. That's why lateral column procedure is a very good procedure to remove the myositis ossificans. And what are the investigations? Routine investigations: ESR, CRP, serum calcium, serum alkaline phosphatase, and CPK, and 24 hours prostaglandin E2. So you see this picture. Classically, this side it is denoting the the amount of that particular thing, and it is in duration of the weeks. You see this first one, the calcium, serum calcium levels are dipped in the initial 2 weeks, then it reaches plateau by the time of 1 month. So in the initial phase, first 2 weeks, then you take the CPK, creatine phosphokinase. It is indirect sign of injury to the muscle. The brachialis muscle that is indirected, if it is elevated, means there are high chances of getting myositis significans. So this is an important landmark to tell whether the patient is having more or less. And another important thing is serum alkaline phosphatase. Serum alkaline phosphatase will take heights after 4 weeks, and it reaches by the time of 2 to 3 months. 2 to 3 months. After 3 months, it gradually declines and reaches 6 months. Reaches 6 months, it is completely quiescent. So after 6 months, the maturation is complete. But here, CRP also it is raised and it gradually declines. First initial 1 month, 2 to 3 weeks, it is initially there is a rise. That's why the infection will come into the differential diagnosis in the initial 2 to 3 weeks. So later on, it gradually declines. So that's why when it appears, when it declines, how long it produces, prolongs. This is also important thing to differentiate from the infection and maturity of that particular ectotopic ossification. In X-ray, you can see that in the phase 1, a fluffy wool appearance, irregular one. Then in phase 2, it is the consolidation pseudo tumor phase. You can appear that mass is appeared and it is connecting from the cortex to it is the radial side. Radial side. In the phase 3, it is matured and you can see the clear cortical borders. Clear cortical borders. So CT scan will give you information about the relation with the neurovascular structures. It will guide you. And ultrasound, you can see that there is a hypoechoric area, which is high cellular area, and a peripheral calcified area. That means peripheral calcification. And above that, a hypoechoic area, that means muscles that is superior to this particular mass is clearly differentiated. If it is a malignancy, you cannot see this hypoechoric area above the hyperechoic area. So this is how ultrasound is useful to differentiate malignancy from this. And these are all the things you can radiologically, you can see the eggshell calcification. Clearly, you can see it. And internally, there is a lucency. And CT also it will give you. But in MRI also, you can see that there is a hyperechoic shadow, hyperdense area. And peripherally, there is a bone. And it is the fluid. Bone scan. It's a technetium 99 commonly used. This is useful for prognosis and activity of the lesion. Lesion will tell you. Most of the time, these bone scans are positive up to 6 months to 18 months. 18 months, the bone scan will tell you about the aggressiveness of the heterotopic ossification. Treatment is conservative and operative. Conservative management, you can give it bisphosphonates and indomethacin 25 milligrams 3 weeks. And low dose radiation, you can give it 700 rads, you can give it, and it should be given within 3 days. Why? Because all pluripotent cells are sensitive for the radiation only within 3 days. That's why the timing is also important. If you give this strength less than 530 centigrade, it is useless. It won't work. That's why you have to give it at least minimum 600. If you give it more than 3000, definitely it will produce carcinoma. If it is less than 3000 centigrade, there is no chance of getting any malignancy. Nothing to worry. And then in the initial stage, aggressive active movements only you have to give it, no passive movements, and the dynamic bracing. And when you ask for the surgery, it is important. Timing of the surgery is also important. Once it is matured, then you can operate. In a post-traumatic stages, you can exercise this heterotopic ossification in 6 months duration. In the spinal injuries, 12 months duration. In head injuries, always you try to prolong it. It is 18 months because growth factor is still producing by the head injury. More severity, more heterotopic ossification. Phase 2 and 3 are very important to do the surgery. In the phase 1, never attempt surgery because you cannot identify. And radiological evidence of intact ulnohumeral joint. This is the one very important. In all heterotopic ossifications, always it maintains radiological evidence of radio-ulnohumeral joint. So after excision, you will get very good results with this. And ectopic bone is matured or not, you should assess. How do you assess this, whether it is matured? Assessment of maturity is clinical, radiological, investigations will help you, and biochemical markers. No, clinically, there is no local rise of temperature and tenderness and no edema. And biochemically, you can alkaline phosphatase will come to the normal and bone scan becomes inactive, and it will take at least minimum 18 months duration. But which one is the best one? Serial X-rays is the best one to tell that a clear-cut cortical border means that heterotophic myositis is matured. So serial X-rays are the best one. You have to take serial X-rays. So by the 18 months duration, metabolically active bone becomes quiescent and tissues regain its equilibrium. So surgery can be contemplated on these patients. And the advantages of early resection. Can you do it in the phase 2 and phase 3 completely? So advantages with early resection is in the traumatic issues, limiting the capsular and ligamentous contractures, and it limits the muscle atrophy because you can do the physiotherapy, and it limits the cartilage degeneration because with the joint motion, cartilage will get the regeneration and allow more rapid rehabilitation. And technically, it is easy to remove because if it is more older and more contractures will be formed and more soft tissue dissection has to be done. So if it is early, less soft tissue additions, it is easy to remove. So timing, as I said, it is followed. So my question to my seniors, I have no experience whether it is an early resection of this. Is it really advantageous, or student can answer this in the examination? You please clarify for the students for the early resection. And the physiotherapy protocol you have to do. And 3 weeks static progress sprint, alternative flexion and extension, and splinting in desirable position at night, opposite movement at the daytime. So this is algorithm, stiff elbow in acute and less than 6 months and more than 6 months. And you have to see for ectopic ossification is there. If it is there, bony bridge, resect, ectopic ossification, and capsule and ligamentous, you have to follow the column procedures. And no ectopic ossification, extrinsic, it is the posterior capsular release, and intrinsic, it is the adhesions and the articular deformities. And other one is impingement, it is an intrinsic one, coronoid and olecranon impingement. And articular, it is the acceptable surface, that is release, and distraction is, you have to do it, distraction. And less than articular surface cartilage involved resurface procedures and distraction can be done. If it is more than 50% articular in the young, you have to do the interposition arthroplasty. If it is more than 60 years with more than 50% of the articular cartilage involved, you have to go for elbow replacement. Thank you.
Thank you very much, sir. I think these 4 C's, they are applicable to you today. Clear, crisp, conceptual, and clearly it is very much Gagar mein Sagar. Means in a nutshell, you have explained very nicely. So the king of mnemonics is befitting with today's class. Thank you very much, sir. I would like to request Bhupa Kumar sir for his comments first.
It was an excellent talk on one of the common topics that is asked for both for the theory as well as for the practicals. And he has dealt it very well. He started with the definition of stiff elbow. Then he went into the stability of the elbow. What are the factors, the extrinsic and the bony stability, that is the primary stabilizers of the elbow, which are the bones, capsule and the ligaments. He dealt with the lateral ligament of the elbow, medial ligament of the elbow. And then I think he came to the causes of stiff elbow, both traumatic and non-traumatic causes of stiff elbow, and the extrinsic and intrinsic causes. He dealt extensively with the classification of stiff elbow. I think the students should at least know 1 or 2 classifications. Then the pathogenesis, the role of myofibrils and mast cells, the genetic theory, all these, and one thing he stressed was the importance of certain medicines like ketotifen, where it is acting. For example, mast cell stabilizer, that may be a future for prevention of stiff elbow. Then the clinical features we have dealt very well. The investigations, the conservative as well as the surgical treatment. And even when the students will be remembering all the names of the Westerners, they will forget to remember the name of Shailendra Bhattacharya, who is an Indian who has done extensive work in the elbow. Then he went to heterotropic ossification. What is heterotropic ossification? The types, the pathogenesis, then the classification regarding the clinical features, what is mature myositis, what is an immature myositis, and when to do surgery, what's the conservative treatment. All these he has dealt. So I think he has almost went to the whole of the topic of stiff elbow, and it will be very useful for the students. Thank you.
Thank you very much, sir. Before taking comments from other senior faculties, I would like to, Sivananda sir, question to you. What is relation between head injury and heterotropic ossification?
The
He
head
told
injury,
us,
there is, I explained,
Yes, sir.
in the head injury, there is an osteoblastic growth factor is released, a hormone that is released that is responsible for the osteoblast that is converted into the heterotropic ossification. So that is the reason why osteoblastic growth factor release in head injury. So especially in this head injury with elbow trauma, so 80 to 90% of these people will get the heterotropic ossification and stiff elbow. So this is the most important thing, head injury with elbow injury. Pure head injury, it will give only 10% of the people you will get this heterotropic ossification.
Thank you, sir. Sir, now question to all senior faculties. What Sivananda sir left that question to all senior faculties is early resection of myositis ossifications. Gopakumar sir.
I think it is much better to say that during the early days, you will just immobilize and then gradual physiotherapy and excision only when the myositis have become mature. The usual answer that is expected is when the density of myositis equals to that of the mature bone, you call it mature myositis. So the density is equal to that of the normal bone. Then you call it a mature myositis. At that stage, you will exercise it. Practically, I have done a few cases of post dislocations of the elbow with immature myositis, and they have done very well. But I will not advise it for telling in the exams.
Thank you, sir. Mohanty sir,
yeah,
anything you would like to add?
It was an excellent lecture. Yeah.
Regarding
Sivananda
early resection, sir. Regarding early resection, anything you would like to add?
No, the classic answer in the examination would be when the myositis gets matured, then it requires excision. And also, sometimes we ask that when the enzyme levels are high, the alkaline phosphatase levels are high, probably it is still metabolically active. So when it is metabolically active, then if you exercise, there are chances of recurrence. So we tell that alkaline phosphatase, classic answer in the examination would be alkaline phosphatase should come down to normal, and X-ray shows a dense mature laminal bone, then it should be excised to prevent a recurrence.
Sir, to all the faculties, any condition specifically you would like to do early intervention and early resection? Takatkar sir. Sir, please unmute yourself.
See, as Gopakumar sir and Shubhranshu both have mentioned, I think till the myositis is active, if there are clinical signs of warmth, the enzyme levels are high, I think you should refrain from touching that myositis. You must allow the myositis to become quiet, and then only you should excise it. That is what we have been following for all these years.
Sir, thank you, sir. Now, sir, your comments, sir. Kakatkar sir.
I think it was an excellent talk on stiff elbow, and he covered it very well, right from the historical aspect to anatomy, the stabilizers, and then the pathogenesis, the classifications, the clinical presentation, what important points in the history taking the student should keep in mind. I think it was a very systematic approach to the stiff elbow, and I think you have covered, Sivananda, almost every aspect of the stiff elbow, right up to the treatment, where you have included the treatment of all the known complications which result into stiff elbow. I think you have covered everything. One point which I would add is one of the cases that you can get is a old unreduced dislocation of the elbow, which can result into a stiff elbow. And I think in that particular condition, I think the choice of approach has to be a Campbell's approach, because what happens is that there is a triceps contracture because of the persistent posterior dislocation. So by going by Campbell's triceps tongue approach, you can get lengthening of the triceps, and in addition to getting excellent exposure where you can reduce the elbow, you can get lengthening of the triceps, and the functional recovery is always very good. That's one of the conditions which I think I would like to additionally mention.
Thank you,
Otherwise, I
sir.
think it was an excellent talk.
Thank you very much, sir. Kalra, sir.
Excellent talk, sir. I have little experience. I know this one of the common case kept in the DNB and MS exam. This is a very common because a lot of short cases are given for elbow, stiff elbow. We have done some short thesis program on deformity correction, and few cases we corrected by Elizarov method, and that too when it was a soft endpoint, not a where you have a you always examine you have a bony endpoint or a soft endpoint. If physiotherapy is not helpful in a soft endpoint, initially you can try before 6 months. In chronic stiff elbow, we have done that Lizero method, and we could change the arc of motion, but arc remains the same. Suppose the better functional arc is regained. Suppose he is not having a full extension, he wants better 30-degree, up to 30-degree flexion. So we could achieve that very easily by a Lizero method. Another thing is, this is a very common short case. That's all. Excellent talk, sir. Thank you.
Thank you very much, sir. Shubhranshu Mohanty, sir. Mohanty,
Yeah,
sir.
it was an excellent talk, and I myself learned many things. The best thing is that it was a clinical approach to a stiff elbow with a little theoretical background, but clinically how the student should present, how to examine, and there is a treatment algorithm of the stiff elbow which was given. And another important thing is that you get ectopic ossification and myocytic ossification cases, and so that is also covered here. Two important things. One thing is that this columnar approach, what you tell, is it a collateral approach? That means you go medially, laterally, because Dr. Bhattacharya's approach is arthrolysis. We go collateral approach, both medially and
Yes, sir.
laterally.
Yeah.
So
Collateral approach, sir.
okay, so the collateral approach, normally we expect the answer as a collateral approach, Dr. Bhattacharya's approach. Both medial and laterally you approach the elbow and then do the thing. That is one point I wanted to clarify. Second thing is, stiff elbow is that the 100-degree range of motion is the stiff elbow that is given in the literature. Because in knee, if you tell a stiff knee, it is less than 40 degrees of range of movement is called as a stiff knee, free range of movement. That means it may be 0 to 40, or it may be 30 to 70. Less than 40-degree free range of movement is called as a stiff knee in the literature. I don't know about the elbow.
Sivananda, sir.
If it is a 90 degrees, more than 90 degrees arc is there, but less than 100.
Okay.
That is mild. If it is classically it describes.
If it is suppose 20-degree flexion deformity, 120-degree flexion, usually it may not require any treatment.
No treatment, sir. That's why no treatment is required.
Yeah, no treatment is required. Okay. So learned a lot.
Always
Thank you
gaining the
very-
flexion is more important than the extension.
That's
Okay.
true.
Always.
Yeah, that is true. That is true.
Anything
When,
less than 100. Yes, sir.
Okay. When Dr. Gopal will share the video again, I would like to see again to learn some more things. It is very,
We'll do
very
that,
nice,
sir.
lecture.
We'll do
Thank you
that.
very much.
We'll do that, sir.
Because,
Uday Kumar, sir. Yes, sir. Yes, sir. Kakatkar, sir.
No, we lost the link in between. So I think.
No,
you
sir.
can see
I have ensured today, sir. Hopefully, it should not be an issue. I have paused at that point, and then when he came back again, started. So hopefully, we should not have that problem. Uday Kumar, sir.
Okay.
Your comment, sir.
Excellent talk, Sivananda. As usual, you did a lot of hard work in compiling all the data, as Gop Kumar sir said, from the history down to the HO. And I have just a little bit of questions from me. One is how long a traumatic elbow can tolerate immobilization, and there is a difference intra-articular and extra-articular. You just explain how long it can tolerate immobilization.
Sivananda, sir. You already...
Non-operative, not operative.
Yes, sir. Yes, sir. Sivananda, sir, you have already explained 3 weeks, but any different answer, sir? Sivananda, sir.
That's non-operative.
Yeah. You are treating a elbow trauma non-operatively. What is the maximum length of time you can immobilize?
Any stiff elbow.
Before it becomes stiff, to gain a normal range of movement.
It is only 3 days, sir. It is given classically. Only 3 days of immobilization is required. After that, you should mobilize.
No. Suppose you are treating conservative, that's what my question is.
Conservative management, sir. Maximum immobilization can be given up to 3 weeks, sir.
3 weeks. Okay.
After
right.
that, you should mobilize. Maximum.
Achha.
So
And
there is
then-
a study. There is a study. It is proven that after 3 weeks of immobilization, the results will be drastically down up to 30%. If you mobilize less than 3 weeks, the results will be up to 80 to 90%. There is a slide is also there. I forgot to keep it in.
The same theory holds good for both intra-articular and extra-articular fractures of elbow?
For intra-articular fractures, you should fix it in a perfect way. Early mobilization is the key for the success.
Okay, early mobilization.
Early mobilization.
So that is the preventive steps. What are the preventive tips you give? So intra-articular mobilize as early as possible. Non-operatively, the optimum period is 3 weeks.
Yes, sir.
So extra-articular fractures.
3 weeks maximum.
Another point I would appreciate is the difference between the malignancy and you have very well enumerated the table. And I am very fond of that table. And one of the DD for sunburst appearance is myocyte ossificans. Just I want to add to what I have already said. Because I tell my PGs in radiology, one of the DD for sunburst appearance is myocyte ossificans.
All PGs should remember when Uday Kumar sir is examiner, what you are supposed to just remember that chart with 4 differentials. Okay, thank you, sir. Kanojia sir.
कनौजे सर पेट्रोल खत्म हो गया क्या?
Sir, I wanted to avoid this word because we have already crossed 9.
कार्ला सर ऑलरेडी चले गए सर, डोंट वरी.
नहीं सर, sir is there, sir. Sir, ऐसा कुछ मत बोलिए, sir is there.
I have refilled my tank.
Sir, Kanojia sir, if you are there, please unmute yourself. Mahle sir, I think he has left. Till the time Kanojia sir comes back.
Sir, you are not audible. No, he is not audible.
Yes, sir.
Okay. Till the time he is coming back, sir. Sir, students have few questions. I think they are all answered, but the questions are: fractures around elbow commonly leads to stiffness. Kindly explain the physiotherapy protocol. Sivananda sir.
Physiotherapy protocols is active movements, only active movements up to 6 weeks. After 6 weeks only, you should advise passive movements. Till that time, you should not advise passive movements. Up to 6 weeks, always you have to give a static progressive range of physiotherapy. That's what I told you. It is a static progressive physio. So
Sir,
you should not get any pain, and with the pain, you should not get any spasm of the muscles. So always it needs a reciprocal relaxation of the muscles, both flexors and extensors. Then
Sivananda
only
sir,
you will get.
at 6 weeks before starting the passive movements, would you like to do any specific investigation? Any investigation, serological investigation you would like to do before starting the passive movements at 6 weeks?
I don't think so.
No, sir, not like that. Okay, sir, because alkaline phosphatase, that phase, first phase, second phase, for that I had asked this question. If some examiner
So
asked
that
this
one.
Gopal,
yes, sir.
well, if you want to really put it on a passive physiotherapy, or some people use even a CPM for elbow, I think one of the important investigation that one should do is to look for the inflammatory markers.
Sir.
If the inflammatory markers are raised, I think you should avoid going in for passive mobilization.
Right, sir. That was the reason I wanted, because his sir has explained in his class. But that point, I think, was required to be stressed. Thank you, sir. One more question, sir. Undisplaced radial neck fracture leads to stiff elbow is common. How to overcome this? This question is from Dr. K. Sanju Kumar, and this is homework for you. Sir will not answer. He has already given you complete pathophysiology and class, but I think we should leave this question for his homework. There is no more question in the chat box. So I think concluding remarks, if Kanoja sir is there. Kanoja sir, are you back? I think he's not there. Kakatkar sir.
He is there,
No,
but then I think his
he's
voice
there,
is
but
not,
he's not audible.
yeah, he's
Okay.
not audible.
Okay, sir. Okay, sir. Sir, then Kakatkar sir, your concluding remarks to conclude today's class, sir.
Yeah.
Sanjeev.
I think it was an excellent class for one of the common problems that we face in the exam as well as in the practice. And I think it was a complete overview of this problem, which Sivananda has covered very beautifully. A word just before we closed on, I was fortunate enough, and I had a privilege to spend some time with Dr. Bhattacharya, because he was a very enthusiastic teacher, and he used to attend these PG teaching programs. And couple of times we have shared the platform together in Indore, which Dr. Jayant Sharma will definitely remember. And the man who couldn't walk without a support used to travel from Calcutta to Indore. He even came once to Nashik in a wheelchair, and he will spend from morning to evening the entire time in the hall to teach the students. Hats off to the enthusiasm. I think those of us who were lucky to see Dr. Bhattacharya teaching and participating in the teaching sessions, I think we have taken a lot of inspiration from him. And I think we hope to continue our teaching mission in the same way as Dr. Bhattacharya continued. Thank you.
Thank you very much, sir. I think for me and all PGs, you all senior faculties, we are really thankful to you, sir. And what you said about Bhattacharya, sir, you were lucky enough to have interaction with him. But for us, you all senior faculties, for we all juniors and residents, they are not less than Dr. Bhattacharya sir. Thank you very much, Kakatkar sir, Jain sir, to have this initiative. Yes,
one
sir.
important line.
Yes, sir.
One important point, usually in orthopedics, we tell that elbow joint is a very shy joint. That's why, earlier it goes into stiffness. That's, procedure to remember.
Sir,
And after
sir,
listening to Sivananda sir's lecture today, I think none of the students should shy away from answering any questions about the elbow.
yes, sir.
We have
Thank
seen
you.
that elbow case when the candidate gets, usually they are not able to answer very nicely. Most of the elbow cases they fumble. Some or other.
One last
So
comment, sir.
after listening to the they should not shy away from answering this stiff elbow questions. Yeah.
Gopal sir, one small comment.
Yes, sir.
Gopal sir.
Yes, sir. Go ahead.
Incidentally, there was a class by Dr. Sriram sir is going on in other channel. That is also on the elbow. He is talking on the injuries around elbow. I seen Sriram sir is still talking. Just sir was telling the Bhattacharya sir about Bhattacharya. So Sriram sir also at his age is very active now. He is also taking classes. For us, Bhattacharya for us is the Kakatkar sir only.
That was the reason actually. I was, unlike my nature, sir. Unlike my nature, I'm not a diplomatic person, but I try to convey the same message. Thank you very much. And sir, like Monty sir said, it is a shy joint. I think shy nerve is a radial nerve. So students should remember that shy nerve means Lazaro bolte hai usko. So touch me not nerve is the radial nerve. And I think this elbow joint is again another shy joint. Thank you very much, sir. With this, we conclude today's session. Sivananda sir, clear, concept-based, crystal clear concept making talk. Thank you very much for that, sir. Thank you, sir.
Kanoja sir has come back.
Yes, sir. Kanoja sir.
Voice.
Kanoja sir, are you there?
Still the voice is not audible.
No,
Okay,
the
sir.
voice is
I will
clear.
take his comment in next class, sir. Thank you very much. We are concluding today's class. Thank you.